So our topic is the touch, pain, temperature, and the physiology involved in this sensory perception. So for our presentation this morning, we'll be talking about sensory modalities involving uh, visual, auditory, vestibular, olfactory, gustatory, but the focus will be on the somatosensory perception, which involves touch, proprioception, temperature, pain, and itchiness, because these are usually the sensory perception that involves the integumentary system, and understanding them will allow us to uh, understand some of the basic uh, physiology and anatomy behind the clinical conditions we will encounter in the clinics. So you will find this in one of your textbook, a table that summarizes the principal sensory modalities. These tables enumerate the sensory system involved in the process, and then what are the modes that can be perceived by these sensory systems, and what are the stimulus that are perceived by the sensory system, and what kind of receptor actually interacts with the stimulus, and finally what kind of cell type that contains the receptors that respond to the stimulus in the environment. So hopefully you'll be able to some sort come to a grip of this framework that is being used for understanding sensory modalities. So what is important to note is that for sensory perceptions, certain receptors, certain sensory receptors actually convert specific forms of energy. So there are different forms of energy in the environment that are perceived by the body, and in turn, this energy, whether it's touch, proprioception, temperature, pain, or sensation like itchiness, or vision, hearing, smell, and taste, are converted into uh, action potentials, basically, in our nervous system. So they are transformed into some form of electrical signals, action potentials in our sensory neurons. So these different receptors in the body, for example, your cutaneous receptors mediate responses, for example, to touch and pressure. So your proprioceptors, for example, in the muscles and the tendon joints, really stimulus that involves stretching and tension, muscle length. We also have thermoreceptors in the body, and thermoreceptors, for example, in the skin, will detect the sensations of warmth and cold. So converting thermal energy into electrical signals in the body. We also have what we call nociceptors. So nociceptors are actually receptors in the body that respond to potentially harmful environmental stimulus, such as stimulus that creates trauma. No? So this is perceived as pain or extreme heat. For example, if you're in a burning building or near fire, which damages the tissue, so it's perceived as extreme temperature, or extreme cold. For example, if you are in a freezer or you are climbing a very high mountain, for example, you will have extreme cold environment, and this will be perceived by your thermoreceptors. Aside from thermoreceptors, we also have what we call chemoreceptors. So chemoreceptors are those receptors that are stimulated by changes in the chemical composition of the local environment. For example, if you get in touch with a certain plant that has a noxious poison, for example, the poison ivy, will come in contact with your skin, or if somebody's angry with you, your ex-boyfriend or ex-girlfriend is so jealous of you and then throws, like, for example, acid on your skin that will be perceive your chemoreceptors. So this will also include receptors for taste, smell, as well as the visceral receptors, no? That are sensitive to changes in the plasma level of oxygen, the body pH, and also osmolality in the body. Finally, we also have photoreceptors. Of course, in the visual nervous system, the photoreceptors function in terms of responding to light, sensation, the presence of light in the environment. And of course, your vision is based on the action of your photoreceptors.
You drink your medicine?
So, but for this session, uh, we will focusing more on the modality involving touch, proprioception, temperature, pain, and even itchiness, which is related to the physiology of the integumentary system. So let's first go to these cutaneous mechanoreceptors. So those receptors that are actually found on the skin. So what are those receptors that we can find in the skin? So you have uh, cutaneous mechanoreceptors in the form of your Meissner corpuscles. So this one here, Meissner corpuscle. You have your Merkel cells. You have your Pacinian corpuscles in the lower portion of the skin, and of course you also have your Pacinian Ruffini corpuscles also, or Ruffini endings. So these receptors actually mediate the sensation of touch and pressure. So all of these receptors involve touch and pressure as sensation. So for Meissner corpuscles, they're described as dendritic, no? Dendritic cells encapsulated in connective tissue beneath the epidermis of your glabrous or non-hairy skin, and they respond to slow vibration. So they are the receptors that are sensitive to slow vibration. Your Merkel cells, on the other hand, are also dendritic uh, types, no, of cells whose endings respond to sensations of stretch and fluttering vibration. So Merkel cells are expanded dendritic endings in the epidermis of your glabrous skin that respond to sustained pressure and touch. So for Meissner, it is slow vibration. For Merkel cell, it is sustained pressure and touch. So they're sensitive to touch sensation. Your Ruffini endings or your Ruffini corpuscles are actually large dendritic endings with elongated capsules, no, in the dermis of the glabrous and hair skin. So they are deeper in the skin layer. They are actually found more in the dermis layer, and their function basically is to respond to stretch and fluttering vibration. Your Pacinian corpuscle, on the other hand, is the largest cutaneous mechanoreceptor. So it's about 2 millimeter in length, and 2 millimeter in length and about 1 millimeter in diameter, that is found in the dermis of the glabrous irises. So just like your Ruffini endings, your Pacinian corpuscle are found in the dermis of the skin. So they are comprised of a nerve ending that is encapsulated by concentric layers of connective tissue. So it gives these layers of connective tissue actually gives your Pacinian corpuscle an onion-like appearance, no? And the function of this Pacinian corpuscle, is to respond to fast vibration and deep pressure. So fast vibration and deep pressure, while for Ruffini endings, it's for stretch and for fluttering vibration. So you would notice that these receptors actually have different receptor field, and you would notice that the Meissner corpuscle and the Merkel corpuscle have narrower fields in terms of reception compared to the wider field of perception of your Pacinian and your Ruffini endings. So noted that if the receptor is located deeper in the skin, they're deeper in the dermis, it means that their field of reception is actually wider, no? So it's more wider, while if it's located more in the superficial layer of the skin, in the epidermal layer, there is a narrow field in terms of reception, but it is much more, let us say, exact. No, it's a much more able to narrow down the specific location of the stimulus compared to the receptors that are found deeper in the dermis. On the other hand, you would also notice that these different sensory nerves from your cutaneous mechanoreceptors are actually comprised of myelinated A alpha and A beta fibers, who are actually very fast conducting. No? So they range from 70 to 120 to about 40 to 75 meters per second. So they're very quick responding receptors, which you will compare later on when we go to the other types of receptors are very fast, no, compared to the unmyelinated fibers of the other receptors in the skin. Also take note of aside from the location in terms of the intensity of and the time course of the stimulation that are perceived by your receptors. So for the Meissner corpuscle, it's more quick, and then it fades away. While for Merkel cells, it is more sustained. So that's why it is able to respond to sustained pressure and touch. While for Meissner corpuscles, it very quickly dissipates. So they're able to respond to touch very quickly, but then it quickly dissipates also. While for Pacinian, it's also different from the Ruffini endings because your Pacinian corpuscle actually very quickly dissipates, while the Ruffini endings can have sustained stimulation, no? Throughout the period where it is being exposed to the stimulus. So the human hands, therefore, in summary, have 4 types of mechanoreceptors, and their activation produces the sensation of touch, no? Or contact with an object. So if you have activation of your Merkel cell and your Ruffini cell endings, they cause sensation. So your Merkel and your Ruffini endings cause a sensation of steady pressure, while your Meissner and your Pacinian receptors causes tingling and vibratory sensation. So a receptor will only fire when the skin close to the sensory terminals are touched. So they will only respond to stimulus if the receptor fields are in close contact with the stimulus. So the receptive fields of your mechanoreceptors differ in sizes and responses to touch. So your Merkel cell and your Meissner corpuscles actually provide the most precise localization, as they have the smallest receptive field compared to the other mechanoreceptors. No? So these two are the more precise, and the Pacinian and the Ruffini have the wider field of reception. So in terms of stimulus intensity, it is signaled by the firing rates of your individual receptors, and the duration of stimulus is signaled by the time course of the firing. So the spike train here indicates action potential that are elicited by pressure from a small probe at the center of which resistive field. So you will notice that your Meissner and your Pacinian corpuscle, so your Meissner here and your Pacinian here actually respond rapidly. So they adapt rapidly. So they quickly dissipate in terms of the neural spike trains here. It immediately dissipates compared to the sustained slow adapting Merkel and Ruffini endings. Okay, just for review, let's now go to slido.com and see if we can get this question for participation. Are you there already? So China is there already. Sarah Jane, Jing P. Okay, we need more people to join us. We have 6 already, 8. Okay, so about the rest, wala kayong other window. Okay, we'll wait for until we have about 10 to 12 participants before we start para mas marami tayong participants. Okay, one more. You can just, yeah, okay. So here we go. So which of the following cutaneous mechanoreceptor is correctly paired with the type of stimulus to which it is most apt to respond? So as alin dito yung tama sagot? Pacinian and rapid vibration, Meissner and skin stretch, Merkel and slow vibration, corpuscle and sustained pressure. What's your answer? So which of the following cutaneous mechanoreceptor is correctly paired with the type of stimulus to which it is most apt to respond? Okay, so all in na ba? May hahabol pa?
Doc, bakit hindi po nag-appear ang name ko, Doc, kahit na enter ko na po yung code?
Kailangan mong i-type yung name mo because there is a field there where you have to join. You have to type your name para may pangalan ka. So you have to put a name and then join.
Okay, okay po, Doc.
So you have to type your name so that you'll be able to join. So there is like a field there where you have to put in your nickname. So pwede malagay doon Superman. Or you put your initials, or so just put your name there. Okay. So sige. We have about 15 participants in the room. 12 have already answered. 13 have answered. How about the 2? Okay, so let's check kung tama ba yung sagot natin. So, hindi. Okay, so 57% answered corpuscle and sustained pressure, and 43% answered corpuscle and rapid vibration. The correct answer is corpuscle and rapid vibration. So, yun po yung tamang pairing po natin. Okay, so very good. Thank you for participation. So that's for your cutaneous receptors. Let's now go to your nociceptors. So your nociceptors are the receptors for pain and temperatures. And your nociceptors can be further classified into mechanical, thermal, chemical, and also polymodal. So it's important to note that when you talk about nociceptors, you're actually talking about receptors that are able to detect what we call noxious stimuli, or let's say nakaka-create ng irritation or pain sa atin. No? So they are stimuli that we perceive as not pleasant. So that's why they're called nociceptors. And there are different mechanisms by which the body is able to detect unpleasant sensation. So Pain and temperature sensations arise from receptors located on unmyelinated dendrites, subsensory neurons located throughout the glabrous and hairy skin as well as deep tissue. So now alam natin ang difference between the cutaneous mechanoreceptors compared to your nociceptors. Yung cutaneous mechanoreceptors na diniscuss natin kanina, they are myelinated, no? While your nociceptors are actually located on unmyelinated dendrites of sensory neurons. So ibig sabihin nun, mas fast yung response ng mga cutaneous mechanoreceptors compared to the nociceptors because of the difference in terms of myelination. So let's first take a look at the mechanical nociceptors. So mechanical nociceptors respond to strong pressure. So for example, if you poke your skin with a ball pen, you're actually stimulating your mechanical nociceptors, and you're able to identify the exact location of the sensation because of your cutaneous mechanoreceptors. However, your mechanical nociceptor will also perceive this as a strong pressure, no? And eventually, if you press hard enough, it will become an unpleasant sensation. On the other hand, thermal nociceptors are activated by skin temperatures above 45 degrees Celsius or below 23 degrees Celsius. So ito yung temperature ranges that are perceived as uncomfortable already, either too warm or too cold by the body. So above 45 or below 20 degrees Celsius. That is why when you are in a very cold room, for example, naka-turn on yung aircon, below 20, minsan naging uncomfortable na yung feeling natin because of the severe cold. Or nandun ka naman sa isang mainit na lugar, for example, above 45 degrees Celsius, o nasa labas ka ng bahay and then the temperature outside is above 45, it creates unpleasant sensation also to the body. So because of the thermal nociceptors in our skin. Also, we have chemically sensitive nociceptors. So chemical receptors that are sensitive to chemicals such as bradykinin, histamine, high acidity, and even other environmental irritants, no, that are around us. For example, exposure to pollen, to plant poison, no, that are on the surface. So ang chemical nociceptors are the one that respond to these stimulants. Lastly, we also have what we call polymodal nociceptors. Your polymodal nociceptors respond to a combination of both mechanical, thermal, and also chemical. Ito yung mga receptors that are able to respond to different types of stimulation. So impulses from the nociceptors are actually transmitted through your thinly myelinated A delta fibers, 2 to 5 micrometer in diameter, that conducts at a rate of about 12 to 35 meters per second, and also unmyelinated C fibers. Ito yung mga unmyelinated fibers that are about 0.4 to 1.2 micrometer in diameter. And they actually conduct at a low rate of between 0.5 to 2 meters per second. So if you compare that to the speed, no, of the sensory mechanoreceptors, cutaneous mechanoreceptors that we discussed earlier that have about the speed of 100 meters per second, this one, the nociceptors in the unmyelinated C fibers only travel at around 2 meters per second. And even if you have some thinly myelinated A delta fibers, kasi kanina yung previous na mga receptors, they have A alpha and A beta. So they are thicker in terms of myelination. Yung A delta is thinner in terms of myelination. So therefore, they're slower in terms of the conduct. So the maximum is about 12 to 35 meters per second. So they're still slower compared to the previous receptors. So when you activate your A delta fibers, it releases glutamate. No? So glutamate is a chemical released by your fibers that is responsible for what we call fast pain. No? Fast pain. Ito yung unang pain. So glutamate is the mediator for what we call fast pain or first pain that we feel. which is the body's rapid response and therefore mediates the discriminative aspect of pain and is able and enables us, no, as individuals to localize the site and intensity of the noxious stimulant. So pag kinusok ka ng matalim na bagay, the response of your A delta fibers that respond to mechanical pressure, for instance, from a sharp object, will be to release glutamate, and glutamate will be the one responsible for the sensation of fast pain. On the other hand, activation of your C fibers. So yung C fibers natin, ito yung mga unmyelinated fibers. So wala silang myelin, so therefore we expect that the action potential will be slower. So the speed of conduction will be slower. Once they're activated, they will release a combination of your glutamate and substance P. So kanina, yung first pain or fast pain, glutamate lang. Pero ngayon, it's glutamate plus substance P. So this combination of glutamate and substance P is now responsible for what we call the second pain, or also called as slow pain. Slow pain. Ito yung parang pain na slower throbbing pain, which is dull, intense, and also diffuse. So hindi siya well localized, no? So parang magkakaroon ka ng headache, kakaroon ka ng dull pain, unpleasant sensation associated with noxious stimulus. Also take note that itchiness is also related to pain sensation, no? And that is why itchiness is also related to noxious stimulation of the body. So what is the chemical basis? So what is the molecular basis for the kind of sensation that we feel when we have stimulation of your nociceptor receptors? So last meeting, in the previous video where I introduced this topic, where I mentioned that the Nobel Prize for Physiology and Medicine this year was won by two scientists who are working on pain receptors. They're actually looking at this molecular basis, for sensation, for pain sensation, and what are the specific mechanisms, how this sensation is perceived. So in the textbook, this is what we have, and hopefully we will have an updated version of this once their work is incorporated into the literature. So what we have, based on our current understanding of nociception, or perception of pain, a variety of receptors on the endings of your nociceptive sensory nerves will respond to unpleasant or noxious thermal, mechanical, or chemical. So we have here in this figure, you will have thermal. So meron tayong cold or heat, no? So you notice that your thermal, either cold, less than 20, heat greater than 45 degrees Celsius, will stimulate this receptor, your TRPM8 receptor and your TRPV3 receptor. So these are your transient receptor potential channels. Transient receptor potential channels, TRP. And they are abbreviated either to M8 or V3, depending on the specific chemicals to which they actually respond. So for example, your TRPV1 is actually your transient receptor potential V1 receptor, V referring to a group of chemicals called vanilloids to which they respond. And so your TRPV1 receptor, for example, which responds to heat, so greater than 45 degrees Celsius, and to acid, hydrogen ion, acid chemicals, are activated by heat, acid, and also chemicals like capsaicin. Capsaicin, if you remember, is an active ingredient in hot pepper. Yung nahilig dito sa atin ng mga maaanghang, that sensation of heat and even pain that we feel when we eat our hot chili food. Ako mahilig ako sa maanghang, no? I love to eat hot spicy foods, and it is due to the chemical capsaicin, which is actually found in hot peppers and is actually an example of a vanilloid. So that's why it activates this receptor as part of the chemical family called vanilloids, and therefore creates the sensation of pain and heat. No, so that's aside from the other chemical that actually stimulates these receptors. So your TRPV1 receptor can also be activated indirectly. So indirect activation of your TRPV1 can be done via initial activation of your TRPV3 receptor in the keratinocytes of the skin. So mayroong mediation dito. So indirect mediation through your TRPV3 receptor. So question mark pa yung exact mechanism receptor. So maybe ito na yung na-discover. Ano? I have not actually read yet the paper, the study done by the two scientists who did this research. Baka ito na, elucidate na kasi dito question mark pa siya. No? Baka nakita nila kung ano ba yung specific receptor na yan that can also be activated to produce a sensation of heat and pain. So your noxious mechanical, cold, and chemical stimuli may also activate your TRPA1 receptor. So A stands for ankyrin. So TRPA1 receptor on the sensory nerve terminals. So sensory nerve endings can also have what we call your acid sensing. So ito acid sensing ion channel. So ASIC, acid sensing ion channel receptors that are activated by pH changes within the physiologic range of the body. And they may actually be the dominant receptor to create the sensation of pain that are induced by acid. So pag yung skin natin, mouth natin, kumakain tayo ng mga acidic or na-expose tayo sa acidic substances, so this receptor might be the dominant mediator for the creation of pain, no? Sensation of pain. So in addition to the direct activation of receptors on the nerve ending, some painful stimuli release intermediate molecules that will then activate receptors on the nerve ending. For example, nociceptive mechanical stimuli can cause the release of your adenosine triphosphate that will then act on your purinergic receptors, for example, your P2X. So for example, mechanical receptors are stimulated because of stimulation that will release adenosine triphosphate. Then it will stimulate your purinergic receptor or your P2X, which is an ionotropic receptor, and also your P2Y, which is a J protein coupled receptor. And then this will create the sensation of pain. You also have your tyrosine kinase receptor, TRKA1, and also the, which activates your nerve growth factor that is released due to tissue damage. So currently, this is the current model, no, for understanding how different noxious or let's say unpleasant stimuli, either thermal, cold or heat, mechanical, or let's say chemical in the form of acid or other substances, induces the sensation of pain and temperature in the body. So an interesting clinical condition that we might need to take a look much more deeper in this session is what we call itchiness. So itchiness is an unpleasant sensation of the body, no? Or we call that also pruritus. For healthy people, individuals who have no problems, itchiness is not a problem. But severe itching can happen in medical conditions, for example, chronic kidney disease or liver disease or atopic dermatitis or even HIV, no, patients, they may manifest as severe itching or pruritus. And they have discovered that there might be actually itch specific sensory pathways. So mayroong pathway sa katawan natin that actually mediates the sensation of itching. No? Since they discovered that itchy spots can be mapped on the skin, and there are each specific fibers that have been identified in the ventrolateral spinothalamic tract. So mayroong pathway, no? Mayroong pathway for itching sensation in our nervous system. So take note that your itchiness can be produced by a variety of mechanisms. One is repeated local mechanical stimulation. It can also be produced by chemical agents like histamine and urokinase. So that is why when you have allergic hypersensitivity reaction, the mast cell, no, which mediates the inflammatory reaction of the body, secondary to allergic reaction, they will release histamine and bradykinin, and it will create the itchy sensation we find in clinical conditions associated with allergies. So they will stimulate these receptors. So kinins, for example, bradykinin will exert their effects by activation of two types of G protein coupled receptors, which are your B1 and B2 receptors. So activation of your B2 bradykinin receptors will create a downstream event where a protease activated receptor or part 2 will be activated, which then induce both nociceptive and prurigogenic response. So ito na yun, no? It will create a response that will be perceived as itchiness. So what about the situation where when you have itchiness and then you're able to relieve that itchiness by simple scratching? So pag may parang nakakatihan ka, ang ating response, kinakamot natin, di ba? So when you feel some itchiness in your skin, the reflex response is to scratch it. And the scratching will somehow relieve the itchiness. And what is the physiologic basis for that? The basis for that is because it activates the large, fast-conducting afferents that somehow then gates the transmission in the dorsal horn in a manner that is similar to the inhibition of pain by stimulation of similar afferents. So dahil yung mga so when we scratch our skin, it stimulates the fast-conducting afferents, yung mga nasa sensory cutaneous receptors natin, na di-discuss natin, yung mga A-alpha receptors, yung mga A-beta receptors, then they are conducted to the dorsal horn, and because they overwhelm the signal from the itchiness receptors, then we do not perceive itchiness anymore. So that is the mechanism for the scratching reflex, which relieves that sensation of itchiness. On the other hand, we also have medicines like your antihistamines, no, that are used to reduce itchiness. And what's the mechanism? So it is effective in reducing pruritus associated with allergic reaction. So they actually block these receptors, no, and they are able to. So by blocking the beta 2 receptors, they antagonizes the stimulation and therefore will reduce the scratching behavior. So beta 2 receptors of your bradykinin, so bradykinin blockers, may be a useful therapy actually for treating pruritic conditions. All right, let's now go to thermoreceptors. Ito naman yung mga receptors that mediate the sensation of heat and cold. So cold receptors are actually found on the dendritic endings of your A delta and C fibers. And the receptors that are activated by your the cold sensations, actually your TRT and 8, no? While your warm receptors are on the C fibers. So therefore, magkaiba pala yung location ng heat sensitive spot at saka ng cold sensitive spot ng katawan. So they have different localization. So your cold receptors are found on the dendritic endings of your A, delta, and C fibers. Warm receptors are found on the C fibers. So if you map to the heat sensitive and a cold sensitive spot in the body, you will notice that there are about 4 to 10 times as many cold sensitive as heat sensitive spots. So ibig sabihin, mas sensitive tayo sa lamig kaysa sa heat. No? Because there are more heat sensitive location in the body compared to the heat sensitive location. Your TRPM8 receptor are activated by moderate cold. So below 20 degrees, na-activate na yung TRPM8 receptor. So your TRPM, M stands for menthol, no? Which is the ingredient in mint that gives it its cool taste. So for example, di ba tayo, pag gusto natin na comfortable yung bibig natin, we take in menthol, it gives us a cooling sensation. So it comes from menthol, which actually is mediated by your TRPM8. So cold receptors are actually inactive at temperatures above 40 degrees, but then suddenly increases their firing rate as the skin temperatures falls to about 24 degrees Celsius. So they become more active once the body approaches colder temperatures. So as the skin temperature further decreases, so for example, umabot siya ng 10 degrees Celsius, nagdi-decrease din yung kanyang firing rate, no? Nagdi-decrease yung firing rate until such time that below 10 degrees, they are inactivated. So yung cold temperature natin, they no longer are able to perceive sensation of coldness. In other words, pag wala na yung cold sensation, ano nangyayari? Below 10 degrees, parang nagiging na-anesthetize, no, yung skin natin. So that's the sensation of anesthetic. So pag humahawak tayo doon sa malamig, no, below 10 degrees of freezing temperature, our skin becomes numb sensation kasi wala ng feelings yan because the cold receptors are inactivated at temperatures below 10 degrees. So that is the physiology behind that occurrence. So your TRPV3 and your TRPV4 receptors on sensory nerve endings are activated naman when the skin temperatures reaches 33 to 39 degrees Celsius and 25 to 34 degrees Celsius respectively. So yung TRPV3 activated siya at 33 to 39 degrees while your TRPV4 is activated at 25 to 34 degrees Celsius. So the firing rate, yung stimulation ng warm receptors will increase further as the skin temperature reaches about 45 degrees Celsius. Ito na yung sinasabi ko na 45 degrees Celsius threshold. Now, once the temperature reaches 45 degrees above, they become silent. Hindi na siya nagfa-fire. And so therefore, what you perceive is no longer heat. What you perceive therefore is pain. So the sensation of heat is now replaced with the sensation of pain above 45 degrees Celsius. So that's the mechanism for being exposed to a very hot surface, no? So pag hanggang 45, you just perceive it as heat. But if you notice it, when you hold a hot object, if it's above 45, hindi na heat yung naramdaman mo, pero pain na. Because the TRPV4 and TRPV3 receptors will no longer fire to create a sensation of heat. So that is the basic mechanism to the sensation. So here is a figure that shows to you what is that, how is this sensations created by different type of stimulation. So for example, how do you generate impulses in the different types of receptors? So for example, going back to our cutaneous receptor, let's say going back to your Pacinian corpuscle, which is onion-like in appearance, no? Here it is demonstrated that different strengths, no, different strengths of stimulation will have different levels of response. So this is one, this is the baseline stimulation, and then this one is twice the strength of the first one, and this one is 3 times the strength of the first baseline stimulation, and this one is the 4 times the strength of the first stimulation. So the strongest stimulus will produce an action potential in the sensory nerve. So there is a threshold that needs to be perceived by the receptor before it will generate an action potential. So the way the activation of a sensory receptor leads to an action potential, this one is. So this one are just generator potentials that are a result of, let's say, stimulation of different strengths. But once it reaches a threshold in which it generates an action potential, then that action potential then is carried carried throughout, propagated throughout this nerve pathway, and will now be perceived as a stimulus effective enough to be perceived by the receptor. So in the posterior corpuscle, a myelinated portion of the sensory nerve, along with the first node of Ranvier of the sensory nerve. So there is a node of Ranvier. So the node of Ranvier is found in between these myelinated sheets. So the first node of Ranvier is found within the receptor. The second node of Ranvier is usually found near the point at which the nerve leaves the corpuscle. So when there's a small amount of pressure, for example, this one here is applied to a posterior corpuscle, there is a non-propagated depolarizing potential. This is non-propagated depolarizing potential, which resembles an excitatory postsynaptic potential. So the receptor, your posterior corpuscle, converts mechanical energy into electrical response. And the magnitude of the electrical response, 1, 2, 3, and 4 times the magnitude, is proportional to the intensity of the stimulus. So this is what we call your graded receptor potential. So the stronger the stimulus, the higher the response, until such time that it is strong enough to generate an action potential. So when the generator potential reaches about 10 millivolts, an action potential is produced at the first node of Ranvier. So this is the location of your first node of Ranvier inside the receptor. And then it continues to fire along the nerve. So if the generator potential is great enough, the neuron will fire again as soon as it repolarizes, and continues to fire if the generator potential is large enough to bring the membrane potential of the node to the firing level. So the node, therefore, the node of Ranvier converts the graded response of the receptor into action potential. So this is the graded response, and then this is the action potential. The frequency of your action potential then is proportional to the magnitude of your applied stimulus. So that is how your receptor converts different types of stimulus, in this case mechanical stimulus, to an action potential, which is a type of electrical response of the receptor. So that is our segue into our discussion of how different types of receptors are actually coded into different types of signals in the body. So there are 4 attributes of a stimulus that we need to take note of. First is the modality, so which is the type of energy transmitted by the stimulus. It's whether it's mechanical, it's chemical. So these are actually different. It varies depending on the stimulus. Then the location, where is the site where that stimulus is applied, and then the intensity is how what's the strength of that stimulus. This is signaled by the response amplitude or frequency of action potential generation. And then finally, the duration. of the stimulus. So the time of the start, the end of response in the receptor. So these four attributes of stimulus is summarized here, no, in this figure, where you have modality, you have location, then you have intensity, and of course you have duration of the stimulus. So a sensory receptor is specialized to respond to either mechanical, chemical, thermal, or electromagnetic stimulus. So each stimulus, each receptor has a specificity to a particular modality, no? Particular modality of the stimulus. Take note that the form of energy, so whether it's mechanical energy, chemical energy, thermal energy, or electromagnetic energy, that is specific to the receptor. No? So the receptor is most sensitive to that form of energy. For example, let's say mechanical. So if it is specific or most sensitive to the receptor, you call that your adequate stimulus. So your adequate stimulus is the stimulus that to which the receptor is very sensitive. So either it's mechanical, it's either chemical, it's thermal, or electromagnetic. So for example, the adequate stimulus for the receptors in the eye, no, which are your rods and cone. The adequate receptor is light, no, light. So it's very sensitive to light. So it responds to light. However, if you close your eye and you poke your eye, that is a form of stimulus also, di ba? So that is now mechanical in nature, di ba? Because it's pressure. And they can still respond to that pressure. That's why sometimes you see stars when you poke your eyes very hard. So sensory receptors can actually respond to forms of energy other than their adequate stimuli. But the threshold for this non-specific response is much, much higher. So you have to poke your eyes hard in order for you to see the stars on your eyes. So pressure on the eyeballs will stimulate the rods and cones, but the threshold of these receptors to pressure is much higher than the threshold of the pressure receptors in the skin. So pag sa skin ka mag-touch, when you put pressure on the skin, it is much more sensitive. Light touch will be perceived by the skin compared to light touch in other parts of the body. No? So also location is important because sensory unit has a receptive field. So the receptive field of a sensory unit is the spatial distribution from which a stimulus will produce a response in the unit. So there is somehow a representation of the senses in the skin. No? So if you map the skin carefully, millimeter by millimeter, for instance, with fine hair, a sensation of touch is evoked from spots overlying your touch receptors. However, pag walang touch receptors doon sa field na yon, doon sa area na yon, you will not have a sensation of touch. So therefore, there will be no sensation evoked in areas where there are no overlying touch receptors. Similarly, in terms of temperature and pain sensation, you can only sense pain and temperature in areas of the skin where there are receptors for these modalities. So also, another concept that is important to note is the concept of lateral inhibition. So this is a very important mechanism to enable localization of a stimulus. So paano natin nalalaman? How do we know the location of a specific stimulus? It is through lateral inhibition. So your information from sensory neurons whose receptors are at the edge, no, peripheral edge of the stimulus, is inhibited, no, compared to the neurons, compared to the information from the sensory neurons at the center of the stimulus. So magkaiba yung responses ng sensory neurons na nandun sa peripheral edge ng stimulus, nasa tabi-tabi, compared to those sensory neurons that are at the center. Kasi yung sensory neurons at the edge of the receptive field is they will not send information to the sides So they will inhibit, so tinatawag yung lateral inhibition. They will inhibit stimulation of the receptors to the sides of the cell. However, doon sa center ng receptive field, they will stimulate all of the fields, all of the receptors beside them. So yun ang tinatawag natin na lateral inhibition for the sensory neurons located at the peripheral edge of the stimulus. So lateral inhibition is the underlying mechanism for the 2-point discrimination test that you might have been exposed to in your clinics, no? When you're trying to pinpoint how wide is the sensitivity, no, of a particular area of the skin to certain stimulation. Tinatawag natin na 2-point discrimination test. On the other hand, the other parameters for understanding stimulus is your intensity and duration. So your intensity of sensation is determined by the amplitude of the stimulus. So the higher the amplitude, no, the greater is the intensity. So as greater pressure is applied to the skin, so the greater, so from this one is just slight pressure, this one is greater pressure. So as you go from very slight pressure to very high pressure here, this pressure is converted to greater amplitude and also to greater frequency of the action potential in the electrical measurement of the stimulation. So weak stimulation activates the receptors with the lowest thresholds, and stronger stimulation activates those with higher thresholds. So this is what we call receptor sensitivity. So as the stimulus is strengthened, no, as the stimulus is increased, it also spreads, no, over a large area to recruit other fibers in the surrounding areas. Ito yung sinasabi ko na recruitment, no, of other sensory receptors to be able to sense, no, the stimulus. So some of the receptors activated are part of the same sensory unit, and the impulse frequency in the unit therefore will increase. And because of the overlap of and interdigitation of one unit with another, receptors of other units are also stimulated, and more sensory fibers will fire if they are near the area of reception. So through this, more and more apparent fibers pathways are activated, which will be interpreted by the brain, no, as an increase in the intensity of the sensation. On the other hand, your duration is related to the fact that if a stimulus of a constant strength is maintained on sensory receptor, the frequency of the action potential will generally decline over time. Itong tinatawag natin na receptor adaptation, no? So if you continue to press that part of the skin in the body, first you feel the sensation. But gradually, when the receptor overlying that stimulus on the skin, no, the receptor on the skin overlying that stimulus, gradually will adapt to the sensation of pressure, and that adaptation will lead to decrease, no, in terms of firing. And gradually, that sense of sensation will decay over time, and then you will no longer feel that stimulus. So receptors can be classified as rapidly adapting, or what we call phasic receptors, versus slowly adapting, or tonic receptors. So, right, for example, your Meissner and your Pacinian corpuscle are rapidly adapting receptors. In other words, you can feel the sensation the stimulus, but once that sensation is sustained, the Meissner and Pacinian corpuscles will rapidly adapt, and then they will no longer fire, no, even with continued presence of the stimulus. On the other hand, your Merkel cells and your Ruffini endings are slowly adapting receptors, so they will continue to fire as long as the pressure is still there. Muscle spindles and nociceptors are also slowly adapting receptors. And different types of sensory adaptation have some value to us as individuals. Because, for example, if you are always sensitive to light touch, no? So may nakapatong yung kamay sa'yo, you feel the touch. But if you continue to feel that light touch, for instance, it would be distracting to us, no? If it will be persistent. Conversely, slow adaptation is also important, no? Because, for example, your slow adaptation of the spindle inputs of your muscles, no, at the back is needed to maintain posture. Kasi kung hindi natin i-maintain yung posture natin, yung spindle inputs po natin will rapidly adapt, then you will not be able to maintain our upright posture. So similarly, input from nociceptors, pain receptors, provides a warning that will be lost, no, if the receptor adapted rapidly. That's why nociceptors generally are slow adapting receptors, because they need to continue to warn us that there is a problem, no? Either it's a presence of a noxious stimulus or a presence of trauma. All right, so let's go back to our slido.com for review, and let's see if you are ready to join the quiz question. So for the next question is, the 4 attributes of sensory coding are. So what are the 4 attributes of sensory coding? So diniscuss pa lang natin yun. Is it modality, adequate threshold, sensitivity, location? Is it adequate threshold, receptive field, adaptation, and projection? Is it specific energy, adequate threshold, sensation, and duration? Is it sensitization, discrimination, energy, and projection? Or is it modality, location, intensity, and duration? So please go to slido.com to answer the question and choose which you think is the correct answer. So we have 8 answers so far. 10, 12. Okay, so see what is the correct answer. I think everybody got the correct answer. Modality, location, intensity, and duration. So let's now go to clinical correlation, no, for our topic today. So I think most of you have conducted physical examinations already. This is part of your competency as a medical student. And one of the things that we're expected to do is conduct a neuro exam. So when we conduct a neuro exam, we actually assess different sensory modalities. No? For example, touch, proprioception, vibratory sense, and even pain. So the sensory component of your neurology exam will include these different sensory modalities. Also, cortical sensory function of the brain can be tested by placing objects that are familiar to the patient, in the hands of the patient, by asking him or her to identify with the eyes closed. So that is also one part of the neurologic exam that we do. Also take note that we also try to assess for pain. So pain is one of the most common reasons that an individual seek advice or consult of a doctor, of a clinician. So pain is a little bit different from other sensation, because pain is some sort of a warning system for the body that there is something that is wrong, and therefore it actually overrides other signals, and generally perceived as an unpleasant sensation. However, pain is a very complex phenomenon, because when tissue are traumatized or when they are damaged, central nociceptive pathways are sensitized and they might be organized. And sometimes when you go to the clinics, you'll encounter patients who complains of what we call a chronic or persistent pain. So we will be discussing a little bit more about pain because this is a very important topic for medical students. So what is pain? Uh, how do you understand pain as a medical term? You know? So generally, according to the standard definition given by the International Association for the Study of Pain, they define pain as any unpleasant sensory and emotional experience. So take note that there is both an objective component and a subjective component to the definition. It is a stimulation, so it is sensed by the body, but it is also an experienced condition, which is associated with actual or potential tissue damage or described in terms of such damage. So this should be distinguished from the term nociception. So pain is different from nociception because nociception is the unconscious activity induced by harmful stimulus applied to sense receptors. So nociception is that process where the body is actually responding to certain harmful stimulus that is mediated by our sensory receptors, and it is generally unconscious. It is not within the realm of our own conscious activity. So when you talk about pain, pain is frequently classified either as physiologic pain or acute pain or pathologic or chronic pain. So bakit natin tinatawag na physiologic yung acute pain? Acute pain has a function. No? Acute pain is considered physiologic because it is generally has a sudden onset and pain will go away when there is already what we call a healing process. So pain that is acute will generally disappear once the body is already able to cope with the noxious stimulus or the trauma or the one that caused the pain. And therefore, it can be considered as a protective mechanism to warn the body that there is something wrong. No? And therefore, the body is able to respond physiologically in terms of healing that part of the body, which is, let us say, damaged. So we can therefore regard acute pain as good pain. No? It's considered as physiologic or good pain because it is an important protective mechanism for the body. However, pain can also become pathologic for chronic pain. Chronic pain is considered as bad pain because long after the body has already recovered from an injury, the body still feels pain long after recovery from injury. So, and what's also noteworthy is that this chronic pain is not responsive to the common therapeutic interventions that we give to patients who have acute pain. For example, they are not responsive to common analgesics, including your NSAIDs and your opioid. So what therefore is the characteristic of chronic pain? Chronic pain is generally a result of what we call inflammatory processes or inflammatory pain or nerve injury or neuropathic pain. And medical or clinical conditions that create neuropathic pain includes your diabetic neuropathy, your toxin-induced nerve damage, and also your ischemia. So take note that risk factors for chronic pain will include age. So the more older a patient is, of course, we will expect that the patient will have more reports of chronic pain. Also, gender is associated with chronic pain. So females have reports of more chronic pain, anxiety, repetitive work, obesity, depression, even nicotine use. No, people who have increased use of tobacco products have increased risks for chronic pain. Now, what is neuropathic pain? Neuropathic pain is a pain that happens when you have injury to your nerve fibers. So your nerve fibers can cause an inflammatory response, no, due to the activation of microglia and the spinal cord. No? And this kind of pain is usually excruciating and very difficult to treat. And the pain will last much longer than the injury itself. Now, personally, I have experienced this kind of neuropathic pain, and I don't want you to experience that because I don't know if it's part of the aging process or if it's genetics. I have some form of cervical nerve damage. No, so I have some osteophytes that compresses some nerve fibers in my cervical region, and it really caused pain in my shoulder to the point where I was unable to move my neck and I was unable to move my left hand. So this happened about a few years ago, and it was really so painful. So it was a form of neuropathic pain that is difficult to treat, and it actually lasts longer than the injury itself. I think this happened because I was doing my PhD studies at that time, and I was always confined to my table. I have to do a lot of desk work, not much opportunity to walk around or exercise. So as a result of that, I had to change my lifestyle. So I have to exercise more and go out more and move as a result of experience. Another condition is what we call causalgia. Causalgia is the spontaneous burning pain that occurs long after simulate level injury. And these are often accompanied by hyperalgesia and your allodynia, and we'll discuss that a little bit more later on. So injured tissues will release bradykinin and substance P, and this will sensitize your nociceptive terminals. Also remember, in inflammatory reactions, you have release of histamine from your mast cells. You also have serotonin, 5-HT from platelets, and prostaglandins from cell membranes, and all of this will contribute to the inflammatory process, and they sensitize your nociceptors so that they become very sensitive to stimulation. And in fact, some release substances act by releasing another substance. So, for example, bradykinin activates both A delta and C nerve endings and increases synthesis and release of prostaglandins, and this creates a vicious cycle where the prostaglandins will also increase the pain sensation of the patient. So remember, your prostaglandin E2 is a cyclooxygenase metabolite of your arachidonic acid, and they are usually released from damaged cell, and they will produce hyperalgesia or very sensitive reaction to painful stimulus. So this explains why aspirin, for example, and other NSAIDs, for example, paracetamol, ibuprofen, your non-selective inhibitors of cyclooxygenase will alleviate your sensation of pain, because prostaglandin is a major mediator of pain sensation. All right, so let's review. I think we are nearing the end of our session. So let's go to another quiz question. So a 23-year-old woman fell asleep on the beach while sunbathing. So na-sunburn siya, of course. So at home, she took a shower, and now the lukewarm water, 40 degrees. So remember, it's not above 45 degrees, so hindi pa siya above the threshold of the warm receptors. Touching her back caused her to feel pain. So what types of receptors were activated by the lukewarm water, and why did she experience pain? So was it thermal nociceptors and nociceptive pain? So what receptors were stimulated, and what type of pain did she experience? So that is the question. So is it thermal receptors and allodynia, thermal receptors and hyperalgesia, nucleus thermal receptors and hyperalgesia, or nucleus thermal receptors and allodynia? So this will segue into our discussion of the difference between hyperalgesia and allodynia. Okay, so we have 7 who have answered. What about the rest? Are you still there? Still awake? Okay, so you have 10 ready. So let's see if you got the correct answer. So 50% answered thermal nociceptors and nociceptive pain. Some answered thermal receptors allodynia, some answered thermal receptors hyperalgesia, thermal receptors hyperalgesia, innocuous thermal receptors and allodynia. So what's the correct answer? So the correct answer is innocuous thermal receptors and allodynia. So innocuous thermal receptors refer to the normal thermal receptors, no? And of course, allodynia will be discussing that in a little while. So what's the difference? So just a summary, congratulations to Lady Faith Julie for tapping our class participation activity. Okay. Okay, it's okay, Aureen. You can join our slido.com class participation next time, no? So Lady Faith Julie is the top notcher for class participation activity this month. So let's discuss a little bit about this concept. So in response to let us say trauma or a lesion, what is the mechanism for sensitizing the body to the presence of tissue damage, for instance? And how does it activate your nociceptors? So there are certain chemical mediators that are released, no, in response to tissue damage. So for instance, if you have like trauma to the skin due to, for example, a knife wound, for example, or abrasion, you will release a lot of factors, no, including bradykinin and prostaglandin. And so this is your nerve ending. So this is your receptor, and then this will activate the release. So the damage to the tissue will release these different inflammatory mediators, including histamine from your mast cells. Of course, substance P is also released by your nerve cells. CGRP that also activates your mast cell. Your 5-hydroxytryptamine, 5-HT is also released, also prostaglandin and also potassium, and etc. So tissue injury releases bradykinin and prostaglandins that will then sensitize nociceptors. So this one is your nociceptors, which in turn will release substance P, and calcitonin generated peptide, which is CGRP. Substance P will then act on your mast cells to cause degranulation and release histamine, which causes activation of your nociceptors. So histamine, as we have seen earlier, activates your nociceptors also. And the substance P will cause extravasation of the plasma through vasodilation. And your CGRP will dilate blood vessels. This will result to edema and additional release of bradykinin. Your serotonin or your 5-hydroxytryptamine 5-HT will release from your platelets and will activate also your nociceptor, making it much more sensitive to the stimulation. So in addition to sensitization of your nerve endings by chemical mediators, you have also other changes that are occurring in the periphery. And the central nervous system also actually contributes to chronic pain. So the NGF, growth factor, released by your damaged tissue, is picked up by the nerve terminals. No? Your new growth factor, nerve growth factor, release is picked up by nerve terminals and transported retrogradely to the cell bodies in the dorsal root ganglion. So the cell bodies of your nerve is here, no? In the dorsal root ganglion, where it will alter the gene expression. So transport may be facilitated by your TRK receptors on the nerve endings. So in the dorsal root ganglion, the NGF growth factor will increase production of substance P and converts non-nociceptive neurons. No? So it converts non-nociceptive, so yung mga hindi sensitive to noxious stimuli, to nociceptive receptors. So they convert non-nociceptive receptors to nociceptive receptors, which is called a phenotypic change. Also, your NGF will influence the expression of your tetrodotoxin-resistant voltage gauge sodium channel on the dorsal root ganglion, which further increases its activity. So, injury, therefore, will sensitize your central nervous system to the presence of the sensation of pain, and therefore will create the condition for the emergence of what we call chronic pain. So, just a side note, there's also a difference between your deep and visceral pain. Usually, for our integumentary system, we talk about superficial or cutaneous pain. But remember, there's also what we call deep or visceral pain that are usually related to noxious stimuli or problems associated with organs deep in the body. So the difference between your deep and visceral pain and your superficial pain is due to the nature of the pain evoked by noxious stimuli. So if you notice in the deep structures of the body, for example, in our organs, in our peritoneum, there's relative deficiency of your A delta nerve fibers. So there's little rapid or sharp pain. Usually deep or visceral pains are not really sharp. They are more, let's say, dull and in nature. So nociceptors are also present in visceral organs, but they are more sparsely distributed than in somatic structures, for example, located in the pain. So therefore, deep pain and visceral pain are usually poorly localized, and they are associated with nausea and frequently accompanied by sweating and changes in the blood pressures, because the receptors in the walls of the viscera are especially sensitive to the distension of these organs, and therefore pain can be severe and prolonged. And usually when you talk about intestinal colic, that is what is characteristic of this pain. It is waxing and waning due to the muscle spasm that occurs after an intestinal obstruction. So that is how you differentiate the pain that you feel from your cutaneous receptors in the skin compared to the pain that you feel in the deep parts of the body, especially involving the organs of the body. So I think that wraps up our discussion for this morning, and hopefully you're able to meet our objectives. So the next module will tackle the biochemical aspects of the integumentary system. Any questions at this time?
None to the